Eddie Cabray here with Cabray Plastic Surgery. Today's patient story, the lip flip. So this 63-year-old presented to one of our dermatologists with this fairly innocuous appearing upper lip lesion. Now, this was a biopsy-proven squamous cell carcinoma. You can see it's very unfortunately positioned on the lip. It involves the skin. It involves the vermilion and the vermilion border and white roll. It involves both philtral columns and the space between. It involves the Cupid's bow component. So really all the critical landmarks of that central subunit of the upper lip are involved with this lesion. And here's the defect. The patient was taken by the dermatologist for Mohs surgery, got clear margins, and this is the defect. Now, it's a central defect. It involves all those critical structures. It's too large and too complex anatomically to just close primarily. Defects up to a third of the lip, particularly the lower lip, can actually be closed primarily, but that is not going to work in this situation. It will result in shortening significantly and also distortion and loss of those critical structures and landmarks. Here's just some side views of the defect. Now, I took her for what is known as a lip switch flap or an Abbe flap. In this procedure, the lower lip is transplanted with the skin and the vermilion from the lower lip to the upper lip in 2 stages, as I'll illustrate. So here's a stage 1 procedure. I've marked out the critical landmarks to help me plan the flap design. The flap is designed as shown here. In this case, the flap's about 2.1 centimeters wide. Now you can see the defect looks different. I've actually excised more skin in a subunit fashion because aesthetically it's far better to reconstruct these defects in this situation by actually removing the whole subunit rather than partial replacement of the subunit of the central third of the upper lip. And here it is. The flap is mobilized progressively as shown here. You'll note that the flap maintains its attachment to the inferior labial artery from that right side throughout. The flap is further mobilized, rotated, and then inset. Now when it's inset into the upper lip, it's closed from deep to superficial of the mucosa, the orbicularis muscle, and then the skin. So there's 3 layers of the lip. Each of those are closed in tandem. And what you can see here is the flap's been rotated a full 180 degrees, and the donor site is still open, and then that donor site is then closed as shown here. Now, this is the end of the first stage of the procedure. What you can appreciate is there are actually 2 oral commissures, or 2 mouth openings that are separate because the lips are still attached to each other such that blood flow can be maintained to the flap after this procedure. So stage 2, division of that connection, the blood flow essentially, the pedicle, occurs about 3 weeks later as shown here. So here she is on the table. You can see that she's healing quite nicely. Here I've divided that flap and given her a single mouth opening, restored the critical landmarks, closed the donor site further. Some side views of that, and here's her outcome. 5 weeks post-op, you can see good healing, good restoration of the aesthetics. Here she is at 2 months. Here she is smiling 2 months. And here's my most recent follow-up at 3 months. Now what you can appreciate, there's been good restoration of the height of the upper lip, the width of the upper lip. We've avoided a critical complication of this procedure, which is making the mouth opening too small, or microstomia. I've restored the critical landmarks to some degree, and we've got good donor site aesthetics, which are continuing to heal. This is just my most recent follow-up in clinic. And here she is smiling in 3 months as well, and some side views as well. So I hope you enjoyed this case of the lip flip. It illustrates a complex reconstruction for a complex defect. As always, make sure your surgeon's board certified. Ask for pre-op and post-operative pictures. Feel free to shoot me an email or question, and look forward to the next patient story.